do anything fun for the Super Bowl? Any fun stories?
Not really.
Yeah.
It was a great game. Yeah.
Yeah,
Right.
I think this is the first year for me where I just sat at home and watched it just with my wife. Just, we've got a 4-month-old, so we're like, I guess we could have invited someone over, but really, it's just one of the times in life where you probably are just trying to just chill out. All right, awesome. I see everyone trickling in. Hello to all. Happy Thursday. We're going to give it just like one more minute for folks to just continue to trickle in. But just want to, welcome you guys to today's panel on behavioral health and risk and all of the above. So to give it one more minute and get started. Excited to be here. This is my first behavioral health panel. So this is the first for me, and I'm looking forward to learning from all of you guys. So it's 12:02. I always wait 2 minutes before we get started, so now's the time. Thanks everyone for joining, and looking forward to the discussion today. I'd like to thank, first of all, Neuroflow for sponsoring today's virtual event so that, we can learn about behavioral health and really get into the weeds here on tactical discussions and so forth. So Will, I'd love to turn it over to you real quick to just give a quick word and we can jump into it from there.
Thanks, Blake. Really appreciate it. And just by a quick way of introduction, Neuroflow is a behavioral health technology and analytics company helping organizations identify risk and effectively manage those individuals in a financially sustainable way. We combine innovative tech with compassionate human outreach, ultimately enhancing risk predictability and reducing the cost of care in complex populations. We're thrilled to team up with Blake and the hospitality team to gather this incredible roster of panelists and dive deeper into this topic around risk management, suicide prevention, and really share actual insights on implementing ways to better measure, address, and integrate behavioral health. Thanks so much, Blake.
Awesome. Yeah, thanks, Will, and thanks to Neuroflow again for sponsoring today's event. Today, my goal is to talk as little as possible so that people who have, been in the field for forever can give their insights and hopefully have some shared learnings. Secondarily to that, we do have a Slido form kind of web browser for folks to ask questions. And on that platform, you can, it's in the chat right now from our digital team. You can, access that and also upvote questions that you think are interesting. So please feel free to jump over to that as we're going through the discussion, ask questions, and we'll have a Q&A at the end. So with that being said, would love to introduce the panelists today. We've got a rockstar cast, and, would like to give you guys the floor. So Tom, how about we, kick it off to you and go from there?
Sure. Yeah. Thanks, Blake. Pleasure to be here. Thank you all for joining. My name is Tom Zaubler. I'm a psychiatrist, chief medical officer at Neuroflow. I've been at Neuroflow for about 3 years. Prior to that, I was a department chair, psychiatry department chair for 21 years, and have been immersed in the world of integrating psychiatry and behavioral health into a multitude of clinical settings, really since my time on the faculty at the University of Washington in the 1990s. University of Washington was where this collaborative care model and a lot of the behavioral health integration work was started. I had the good fortune of having a mentor who actually created that model. So it's really part of my DNA. My faculty appointment currently is with Jefferson Medical School in Philadelphia, which is where Neuroflow is based. I'm a clinical professor there. So nice to be here this afternoon. Should we move it to... Yeah, go ahead.
Nice to have you, Tom. Kristen, why don't you go next, and then Ish will have you round it off.
Sure. Hey, everyone, and thanks for having me. I'm Kristen Tugman. I lead the health and productivity analytics and consulting practice and holistic wellness teams at Prudential. I know that's a mouthful. We are affectionately known as HPAC for short. I've been at Prudential for about 9 years, but I've been in the health and productivity space for 25 years. And actually in the mental health space, which is my first love, for 30 years. And I know that's very hard to believe, but believe it, it's been a long time. And again, I'm just as passionate today, I think, as I was day one getting out of college and starting my career at a mental health facility way down in Florida. Just by way of background, I'm a certified rehab counselor by training, a licensed professional counselor, and my PhD is in industrial and organizational organizational psychology. My team does a lot of work in workplace mental health, helping employers create psychologically safe workplaces and really trying to understand how do we help employees remain as productive as possible. So we do a lot of work in disability as well, trying to help folks return to work from an acquired injury or illness and really get back to life and get back to where they want to be. So yeah, really glad to be here, and I'll pass it off to Ish.
Yeah, thanks. Hey, everyone. My name's Ish Bala. I'm a psychiatrist by background and a medical director at Blue Cross, North Carolina, and I'm also board certified as forensic psychiatrist. I've been at Blue Cross in Blue Shield, North Carolina for 4 years. And just for some background with our plan, we have about 4 million, give or take, members under management. And my role at Blue Cross is to do behavioral health strategy here globally in terms of, my mission here really is to increase access to care to all of our members with any behavioral health need. I'm also a champion of the collaborative care, other integrated care models, as well as direct care that's being offered by a variety of various behavioral health providers. I also do work on medical policy and work with our actuary teams and our network teams to make sure that our plan is providing quick access to high quality care. And I'm also, I'm on faculty at Duke, and used to be in the academic center as well, really as a health services researcher. And now I'm on there, so I've been happy to be here.
Awesome. Yeah. Thanks all for those introductions. Like I said, lots of experience across this panel. So you guys feel free to drop questions, and would love to just kind of, dive into the first kind of segments, which will be kind of setting the stage for behavioral health and like the current, what's going on, what's top of mind for folks. So Ish, maybe, with given your background, we can start with you as far as, what is, a complete longitudinal picture of risk, and why has behavioral health kind of traditionally been siloed?
Yeah, thanks, Blake. So for some background there, I'll say that behavioral health has been siloed from the rest of the physical health world in the managed care organizations, and really in health insurance companies at large. And there's a lot of history there, but I think the skinny is that a lot of behavioral health was carved out of the rest of insurance and health plans at separate separate kind of managed care behavioral health organizations with separate networks and separate ways of thinking about delivering care. And I can understand why it happened that way. The delivery of behavioral health care is different, just is, from the rest of physical health care. One obvious difference is that, for example, the business case of why we want to increase behavioral health services is really because we know now, and probably a lot of us have always known, that behavioral health is part of total whole health. It's not just physical health that drives cost. But there's direct cost of behavioral health through inpatient utilization, psychiatric hospitalization, and so forth, but also a lot of indirect utilization of physical health because of untreated mental health. And some examples of that would be if you're using a substance in addition to having several chronic illnesses, the compounding effect of the cost and the poor outcomes is there. People don't have access to care when they have, on average, when they have behavioral health conditions, they don't have access to primary care. And then finally, I think a big topic for today will be about integrated care, which is when people go to their primary care office provider who they usually have a good relationship with and trust, that they can that it's important for them to be able to get behavioral health needs met. And so, to answer your question, the risk that we see for behavioral health is, if you ignore it and you don't invest appropriately in high quality behavioral health care as an outpatient, you're going to pay for it in some other way. Usually that's from bad outcomes. And COVID, we've seen even that people have bad outcomes when they don't get access to care, and they die earlier. They died earlier from COVID Suicide, which I think we're going to talk about soon too, is another obvious direct cost of treatment, not only completed but also non-completed suicides that result in morbidity and mortality from long-term use. And this is all the kind of thing that we think a lot about from a health plan perspective in terms of de-risking our population and finding the right providers that are able to take care of certain risky populations, and how to incentivize those providers really is the main part of my job, is to make sure that providers are taking on the most risky patients in a sustainable way that they can afford, and not kind of getting into the fee-for-service mindset of taking on less risky people that may never require kind of higher cost medical services.
Yeah. Great thoughts there. And, I think, I'm preaching to the choir when I say like that increase in utilization is top of mind for most payers at this point, right? I mean, there's so like, the mental health crisis is very real. There are a lot of people like aging into Medicare, the youth mental health population that are, suicide is a leading cause of death, and all those things. So, I mean, really, one, from a patient perspective, it's needed. Then two, from, the secondary utilization perspective, it's top of mind as well. I'd love to kind of double click on your comments there and talk about, like kind of like that behavioral health integration. Tom and Kristen, would love to hear kind of your perspectives on, what are the risks to not having behavioral health integrated into your model? Maybe Tom, we can start with you.
Sure. Yeah. So I just want to echo what Ish had said. I mean, this is such a critical issue for us. I mean, psychiatric illness, as we know, is ubiquitous. 20% of the population that has a psychiatric illness at any given time, and we know that most of the time it's missed. The diagnosis is simply missed. 60% of people in any given year with a psychiatric illness receive no care whatsoever. When we talk about integration, the thing that we have to keep in mind is that most people with psychiatric illness present in medical settings. I'm not sure this is as well appreciated or understood as it needs to be, because about 70% of people with psychiatric illness present to their primary care docs, to their oncologists, to their OB-GYNs. They don't present in psychiatric settings. And yet 95% of all behavioral professionals, psychiatrists and others, work in primarily siloed or exclusively siloed behavioral settings. So we have a complete disconnect here. And we know that psychiatric illness drives increased costs, drives increased morbidity, drives increased mortality. I always think of this study by Nancy Fraser-Smith done a long time ago, but a really well done study looking at patients post-MI after having a heart attack. And she looked at two cohorts of patients after they had a heart attack. One cohort did not have depression, and the other cohort did, and controlled for body mass index and smoking and a whole range of variables, lipid levels, cholesterol levels. And what they found remarkably is that 6 months out, 3% in the cohort that did not have depression were deceased versus 17% in the cohort with depression. So the message there is that the reason that it's so important to address underlying psychiatric illness is not just to address the underlying psychiatric problems, that we need to address the comorbidities, because we know that these medically complex patients who account for a disproportionate amount of costs and care in our healthcare ecosystem, the idea that 20% of the population account for 80% of costs, 5% account for 50% of costs, we need to be looking at those individuals who are really struggling. And one of the reasons that they struggle, even though in that distressed high utilizing population, 70 to 80% have a co-occurring psychiatric illness in addition to the multiple chronic medical problems they have. Again, these medically complex patients. The reality is we're not addressing those problems as critically as we need to, and it's driving increased costs. It's driving increased utilization. It's driving emergency department visits that are really not necessary if patients were being treated adequately. And we know that patients with diabetes, in order to treat the diabetes, in order to see their hemoglobin A1Cs and their glucoses start to improve, you've got to address the underlying depression, the underlying anxiety. You've got to surface it and treat it. So the reason that this risk is mission critical is that for our healthcare ecosystem to really function effectively, and it's not functioning effectively right now. As you can hear, imagine if it were cancer, that 60% of patients with cancer receive no care in this country. 90% of patients with substance use receive no care whatsoever. So it's not functioning effectively. So in order for it to function effectively, we've really got to fight this history where psychiatry and mental health has been siloed, going back to schools of moral treatment from the turn of the century prior to this one, the 1900s. And that's persisted. And there are relics of that continue to persist, but it's getting much, much better. But integration is absolutely critical. We'll get much more into this, I'm sure, as the discussion ensues, but just wanted to convey some basic points there.
Yeah, and Blake, I would just add that when we think about access to care, we would be remiss, I think, if we didn't talk about access to care a bit, just in the sense that if we continue to silo mental health, I mean, today, 12% of therapists are accepting new patients. And so that is why we tend to depend on primary care physicians to have the education necessary to feel comfortable to administer a PHQ-9 and assess for depression and anxiety and treat it accordingly until somebody can actually get in to see a therapist. So if we don't get to people before they're in crisis, we will never have enough therapists. And there's a quote I love that it's actually by Desmond Tutu, where he really says, we've got to stop just being satisfied by pulling people out of the river. Rather, we have to go upstream and figure out why they're falling in the first place. And so when I think about integrated care, I think about it in our schools and our communities. We've got to educate ourselves in general about mental health and start to feel comfortable saying to someone, geez, you don't feel like yourself. Are you okay? Because sometimes that makes all the difference. We'd be more than happy to say to someone, geez, you don't sound like yourself. Maybe do you have a cold? Are you feeling okay? We've got to get ourselves to a place where we normalize and equalize mental and physical health in our communities, our schools, and in our medical systems.
Yeah, no, absolutely. I'm curious, like, kind of going a little off the rails, but like, how close do you think we are to like that reality?
I mean, I feel like we're on the precipice of change. In 2018, there was a big change, at least for us that work in workplace mental health, where employers started to see, and you guys probably likely remember, and the audience likely remembers, that the CDC came out and said that suicide rates had gone up in almost every state and by 30% in over half the states. And the work that I do and my team does is, we get a chance to sit across the table from employers and talk about their insurance experience. And so when we started to talk about their life insurance, they started to see that their suicide rates individually were going up within their organizations, and that became unacceptable. And so I finally, after 25 years of workplace mental health, started to see employers say, I need to make a change. We need to prioritize mental health. What can you do to help? And so we did a lot of work with manager training and sensitivity training, employee awareness training, and trying our best in our work with Neuroflow actually to provide increased access to care. And then the pandemic hit. And we saw mental health being talked about more and more in the media. And we started to normalize it. And we started to, I think one of my favorite things about COVID was when we came to work on video, we actually would say to somebody, how are you? And then we would stop and pause and listen. And I think that started to carry through as we've emerged from the pandemic. But that was a big shift where we actually started to not just pass by and say, hey, how you doing? And not really listen to the answer. We started to listen to each other and try to understand if folks were having mental health challenges or just stressors in general. And we gave people outlets to be able to talk. And that's when I talk about upstream, that's really where we have to get to. We have to be able to embrace the fact that we have mental health every single day, just like we have physical health every single day. And we have to pause and listen to each other. And so I think we're on the precipice of change. And I think we have to just keep moving forward and keep talking and keep the research going and keep these conversations going there. I think we've got a shot at this point to make a difference.
Yeah, that's really cool to hear. I love that perspective. And just poking fun at you, I think this is the first time I've heard somebody say, like, one of my favorite things about COVID was.
Well, we got to, you got to find something.
Yeah. There's always a silver lining. I love that optimistic perspective. Well, guys, I'd love to kind of jump into, kind of the next segment as far as like having a more tactical discussion around, what you guys have kind of already alluded to. Kristen, you mentioned kind of chatting with employers and hearing their perspective. Tom, you talked about kind of like primary care and integration with behavioral health. And then Ish, you mentioned, kind of collaborative care models and like interesting models you're seeing. I'd love to kind of just like go around the table and ask you guys some questions. The first of which being, what's working for you guys today? Like, what are you guys excited about when it comes to addressing, the suicide epidemic, SMI, and kind of other behavioral health considerations? So Ish, maybe we can jump off with you and go from there.
Yeah, I can start with so at Blue Cross North Carolina, we took a big swing in this value-based setting that I'd love to just share briefly. Like I said, I've been here for 4 years, and one of the things that drew me to this job was this opportunity to create a unique value-based program for people with SMI. And what we did was that we looked at people that have had a history of high utilization, or, unpredictable high cost utilization, which are indicators that something isn't going right in the community. So we're talking about not a diagnostic based criteria for eligibility or attribution to this program, but one of practicality, which is putting it practically, it's not just for people with schizophrenia that or bipolar disorder that have tried to hurt themselves. It's even for people with, say, panic disorder that go to the emergency department for a panic attack and get a really costly workup with low outcome in terms of addressing the panic disorder. So we grouped this group of thousands of patients together based on claims, and we gave a provider attribution towards moving the needle in terms of improving quality and reducing costs, and showing that they're able to coordinate care. Really, it's a story of care coordination really more than anything. We learned a lot from this kind of value-based model. It's not traditionally something that a lot of insurance companies have been able to do, and was unique. The cut to the chase, I guess, is that we ended up having to insource this program because of a lot of there's challenges. The providers probably have difficulty in living in a value-based setting like this for a high complexity patient population. There's data challenges, there's financial incentive challenges, and then just coordinating care. I've been in North Carolina for 4 years. I think healthcare is different everywhere you practice, and there's a lot of holding on to patients and difficulty in terms of getting patients to the right place because of really just culture that needs to be you need a long time of being in a place and having roots as a provider in order to get those relationships with primary care and even non-healthcare related resources addressing social determinants. So all this being said, we've now done something which I think is also good, is we've insourced this program, and we do all the care management for people that were previously attributed to this external provider. And instead, we do the care management internally. So we do outreach proactively to patients that we think are at high risk. And then we've hired a team, including something I'm really interested in as a peer support specialist that can speak the language of the person on the other end of the phone, because we know that engagement is the number one thing for really any value-based program, but in particular for behavioral health and substance use disorders, even more specifically. Like, a lot of times denial is such an important part of the condition, and having a peer that understands the language has been there versus someone like me who's, I don't have that experience, and so it's difficult for me to kind of sometimes reach the person. So anyway, we've hired a peer support specialist, and including the traditional, providers in the team, like me and the social work, to make sure that patients are getting navigated to our network, which we've also curated to address people with more serious illnesses. So we're doing that work internally now, and we're going to watch hopefully to see, by the way, not just behavioral health providers, but the what I would call reverse integration to the physical health providers as well, because we know that the quality gaps for physical health measures are also really wide for people with behavioral health conditions. Kind of as Tom mentioned with that study with the MI, it's a good example. 5 times the risk of dying after whatever a year of having an MI is. We're seeing the same thing, and making sure that the patients are getting connected to that level of care from a physical health perspective and monitoring of those outcomes is something that we're really interested in as we monitor quality and costs for that population.
Fascinating. Yeah, that's super interesting. After we go around the table, I'd love to hear kind of more about the peer support specialists and kind of like their tactical role. I think that's really interesting, just role in general. Tom, how about you?
Yeah. So first, Isha, really inspiring and great to hear. I mean, I think payers sometimes are really on the forefront of where we need to go and have been real allies in moving this forward. So just want to recognize that, and you're doing great work there. It's what's humbling for me is that I've been in this space for 3 decades. Integrating psychiatry and behavioral health into a multitude of medical settings. And while we have made progress, and Kristen, I agree, I am completely optimistic. I feel like we are on the precipice. We're 30 years into this, and 30 years ago, if I could have talked to my former self or talked to my mentor or colleagues at the time, who are some of the smartest people I know, and said, what's the penetration within primary care and oncology in other medical settings? It's still not great, quite frankly. I mean, 20, 30% have some sort of integration. If we look at patients, where they're getting their care, I've already talked about that disconnect, but only about 11, 12% of patients actually wind up seeing a psychiatrist, and only about 22% of those with mental health problems see a behavioral professional at all. So, we have to be able to think about ways to extend the work that behavioral professionals can do. We know that there are workforce challenges, huge workforce challenges that I think it's over 70% of counties have severe mental health workforce shortages. 55% of all counties in this country have no psychiatrist at all. So, what I'm excited about, and it's not an accident that I'm working at Neuroflow in a technology company, is that technology allows for the scaling and implementation of these models of care in a multitude of settings. Whether it's with prudential and employer-based roles, or whether it's in clinical settings, or payers for that matter, because the idea of surfacing underlying psychiatric illness in a way that allows you to really look at where the populations are at risk, doing the data analytics, the predictive analytics to determine where do you have patients who are medically complex, who are utilizing an extraordinary amount of services, who are just not getting better. How do you identify who those patients are, and how do you get them care? And engagement is very challenging. So, one of the reasons that I'm optimistic is that the technology is such that you can automate the screening process. You can do the screens in the comfort of patients' homes, and there can be self-management tools that are digital self-management tools that are really powerful, that get triggered by the assessments, and the screens get triggered by powerful data analytics. So patients can get digital cognitive behavioral therapy for anxiety, for depression, for insomnia, for pain, for a whole host of conditions, not intended to replace human beings, intended to make humans smarter, intended to serve as an ability to extend the work that goes on in a primary care practice with a clinician, a behavioral health clinician integrated into that practice, or for that matter, behavioral health practice where they just can't see enough patients. Because if you can look at patients and identify them when they have rising levels of risk and provide digital as well as human interventions in a timely fashion, you actually prevent, and we've seen this, 34% reduction in a population at Jefferson that we work with, 30, significant reductions in ED utilization, and the system just runs more smoothly. The other statistic, we'll get into suicide prevention, I'm sure, but, look, we know that, Kristen, you had mentioned that in pre-COVID, it looked like, we were starting to bend the needle a little bit. The suicide rate was actually starting to drop just a little bit, but then it just has gone up and up and up with COVID. So we're now at 50,000 deaths by suicide a year. We're looking at 1.7 million attempts, 12 million people with suicidal ideation. This terrifying statistic that 30% of adolescent girls seriously consider suicide over the past year, 13% attempt, 22% of all adolescents in general. are seriously considering suicide. So this is not a rarefied problem that we can ignore. This is something that is incredibly common, and the onset from suicidal ideation to suicide attempt, studies have shown it's evanescent. It can be as short as 10 minutes. You can take someone who had a normal score on a PHQ-9 or G87, on Tuesday, and on Wednesday, they go into a crisis, a whole number of things, this stress diathesis model of suicide, and they can become acutely suicidal in the flash of 10 minutes. And so what digital technologies do is it allows you to be there at critical moments. And obviously we can't be there for everyone, sadly, but when you are canvassing in the comfort of patients' homes, and when you can provide caring context, the minute they start endorsing suicidal ideation, whether it's through natural language processing, journaling that they do digitally, or through screens and assessments, and then alert providers, or have humans that can reach out to patients as a result of that, it actually saves lives, and it makes a difference. So it's exciting to me that the technology is such that it allows the system to work more efficiently. It actually allows the staffing to be pretty lean, and yet treat large populations pretty effectively, and looking at the risk in large populations and really focusing on those at highest risk. So those are some of the things that I'm really excited about. Again, a lot more to talk about, but I'm sure we'll get to more points.
Yeah, absolutely. And I'll just sort of tag on to the digital solutions idea, because, as we did our work in workplace mental health and really started to think about, okay, we've moved the dial on awareness. We've started to move the dial on stigma, and people are more apt to raise their hand. But what we realized is we weren't doing anything to affect access to care. And so, again, as I mentioned, there's not a lot of therapists that are accepting new patients. And there's a therapist shortage. By last year, the therapist shortage even got worse. And so we've got to get more creative with care. We absolutely, as I mentioned, need to go upstream and get to people before they're in crisis. That's one of the reasons I love the idea of peer support and community support. But we've got to offer alternate solutions that meet people where they are in their mental well-being journey. And so that's what I like about the digital solutions. That's what drew us at Prudential to Neuroflow, because there is a clinician on the back end keeping an eye on what's happening with an individual, so that if they do score a self-harm on positive for self-harm on a PHQ-9, somebody is watching, and somebody is going to be able to reach out, and somebody is going to, the AI will trigger a crisis, the crisis prevention lifeline. And so, to Tom's point, it really is about taking pause. So somebody can go from no suicidal ideation, as he mentioned, within 10 to 20 minutes to suicidal action. But suicidal ideation is also transient. So we know if we can get somebody to take a breath and pause, we have a much better chance of saving life. And so that was one thing that was very important to me as we started to look at digital solutions. But again, we've got to normalize mental health. And so if we can provide solutions that meet people where they are on their journey, then we can provide them the tools that they need at the time that they need them, versus doing what we do today with workplace solutions typically is we just wait for somebody to need something. We wait for somebody to struggle so much that they don't think they can work. And we wait for them to understand how to get care. I mean, if you're not feeling yourself and you're feeling hopeless, it's going to be really hard to look at your intranet at work and find your employee assistance program, or even have the energy to do so. And so that's one of the things that we're trying to solve for within our workplace solution with Neuroflow. I think what's interesting, as we were talking about integration and mental health and other providers really thinking about mental health and taking time to assess the whole person and maybe administer a depression screening or anxiety screening. We have the same problem with disability. So it's kind of, it's sort of two hard things that we're trying to solve for at Prudential and group insurance. And that's having providers sort of integrate in a return to work mindset. So when somebody's out of work, it's very rare that a physician will talk about return to work. And work is a really important part of our lives. It's part of our identity. It's how we remain financially secure. It contributes to our mental well-being. And all too often, we just go office visit to office visit, and a physician will go ahead and continue to sign the person out. And so that takes a toll on mental health as well. And so I've spent most of my career actually studying the psychology of disability and the psychology of return to work, and what precipitates somebody to, feel like the consequence of returning to work is greater than the consequence of staying out of work. And that's really the battle that we're fighting with our business, is how do we get to folks so that they feel prepared to return to their workplace and be productive. And there's a mental health component to that. Every disability event is a psychological event. And so we know that population is also more vulnerable to mental health conditions, which is why we deployed Neuroflow not only to our mental health population in our disability book, but also to all physical illnesses and injuries. And we found that about 36% of our folks that are engaging in Neuroflow have an orthopedic condition. So they're experiencing some form of chronic pain. And these are folks that we would not have known about. And they've triggered urgent alerts where they were feeling suicidal ideation. And we've been able to intervene in a way that's very unique and get them into case management. So I think, to everybody's point, we know there's so much in terms of mental health comorbidity with other illnesses and injuries that we're in our small corner of the world. We're sort of getting at those folks and getting them the resources that they need at the time that they need them. We're really excited to take that concept and move it upstream, as I like to talk about, to full employee populations. So we're starting that work now to really focus on holistic well-being for full employee populations. So we'll keep you posted on the outcomes there, but we're very optimistic that we're going to get to folks at the time that they need the resources and prevent more acute illnesses.
Yeah, that's awesome. Thanks everyone for your answers there. And Kristen, I think that, everybody touched on this, but you specifically at the end there, really talked about kind of the growing need from payers and on health system side for engagement, whether it's having that digital front door or from the payer side, engaging those populations. I'd love to hear kind of tactical ways that, Tom, maybe Neuroflow and each things that you guys have seen success in as far as, engaging and intervening at the right times. Maybe Tom, go first.
Sure. Yeah. No, it's a great question, and one of the things that we see is that if we can go in and canvass a large population and assess that population for risk, several things happen. One, it can be done pretty seamlessly, and it's hard sometimes to convince health systems or others that. Less so payers actually, but that this is something that can be done pretty seamlessly, because there's this change management piece and changing workflows and so on. But the whole point is, it's this quintuple aim of medicine that the equity is critical and unburdening physicians is critical. So what we find is that if we can go in, and whether it's work with a payer or a health system and look at large populations, we can identify those with rising levels of risk, as I mentioned earlier, and sometimes through digital interventions alone, sometimes through a combination of digital and human interventions, prevent those patients from becoming more acutely ill and really transitioning into those distressed, high-utilizing patients who wind up just not getting better medically or psychiatrically. Patients who, on the other end of the spectrum, who are at acute risk, that there are interventions that can occur live, that caring contacts, outreach from humans, guided by all the information provided by the technology to ensure that patients get to the right level of care at the right time. So it reduces ED visits. So what we love to see, and what we do see, is that when we can work with large populations, and we can canvass those populations through these automated screens, and we can identify pockets of risk and provide interventions. And some of those might be integrated programs like collaborative care, behavioral integration programs. It might be referral-based programs. There are a whole range of ways of doing that. But what you start to see is that the ecosystem, it's not just, and I don't mean to minimize the quality of life benefits and the improvements that patients have, but the healthcare ecosystem starts to function more effectively. The emergency room is less cluttered with patients waiting for psychiatric beds that just don't exist. As a department chair in the emergency room that I was responsible for, we had patients waiting, and this was a really great hospital. Patients waiting, very nationally ranked hospital. Patients waiting for days, sometimes weeks, and just horrific. And that was routine. And so if there are things that can be done, and we see the things that can be done to intervene earlier, as you say, Kristen, upstream, to identify the rising risk or identify risks before they become super acute, you actually prevent the ED visits. You make the system work more thoughtfully and more streamlined. Individuals with co-occurring medical and psychiatric illness, when they are admitted medically, tend to stay in the hospital a lot longer. If the average length of stay for a medical admission is 4 days, it's substantially longer when you have those co-occurring conditions. So anything that can be done, both from a patient perspective, from a provider perspective, from a payer perspective, to minimize ED visits, to minimize these lengths of stay in these medically complex patients, is a win. And this is where change management comes in, because we actually have methodologies. When I say, it's not just Neuroflow, but there are methodologies that are out there that can address this in really innovative and creative ways. And so I'm very excited by that. And so those are some of the things that we're seeing.
Yeah, super interesting. I'll bat it over to you next.
Yeah, Blake, so many great things that were obviously already said. I'm not even sure what the question is, but I'll just start talking based on what you guys are
I love
saying.
it.
One of the things is that, we talked about this whole idea of workforce shortage and how to address that problem. It's kind of like, if you want to decrease traffic on the highway, build more lanes, figure out how to build subways and get people to, virtually commute or something like it. But the answer isn't to just build more workforce. I think it's one of the things, but it's not something that's, I think, going to get us out of the crisis. And to me, so digital tools, like I think Tom specifically talked about, employment-based, the psychology of getting back to work and all of that. I think it's really important and interesting. To me, one of the things we think a lot about is, like, at the end of the day, like, I work at an insurance company as a payer. And so we have claims, we curate a network and we pay claims and make sure that those claims are like good, legit, high quality. And we take care of our stakeholders. And so one of the things that we can do, given our data, is this, is risk stratification. We depend on providers to treat the simplest patients as upstream as possible. Really, patients that even before they get, preferably, so that they'll never need any behavioral health treatment. And then also just educating PCPs, I think, is another piece of this that, right now, a lot of PCPs don't feel comfortable treating behavioral health conditions. It's not part of the ACGM requirements to do. I think some of that thinking needs to change. I think there's been a lot of, destigmatization efforts that I think are, of course, a fan of. But on the other hand, when you take away stigma, it's going to increase demand. There's not as much supply. So you have to be kind of smarter with the resources that we have. And so, to me, like, something that I'm hopeful about is that we have this ability to using tools that I'm excited about, but not exactly sure what the answer is. But we do have ways of stratifying using technology and probably AI and machine learning, navigation to the right provider so that people don't bounce around between many providers and are getting to the right one earlier on, so that there's the right match. The predictive analytics around risk, and then monitoring over time that when treatment is effective and making sure that our providers are not keeping simple patients in care for a long period of time, to make sure that they're treating towards a goal so that they have time to see patients that are new and aren't just incentivized to see the same patient population over and over, fill up and then never take on new patients. And then finally, it's like using all this to, like, from a payer perspective, determine what we mean by quality and behavioral health, and then appropriately reimburse for what we want to incentivize from a behavioral health standpoint in the grand scheme of things. Like, so how do you, when I think there was a question in the chat, like, what are payers doing to increase the network size for therapists? And one of the things that we always talk about is, what are the rates that we pay for providers? And it's often difficult. Providers will come to us and say, we demand a higher rate. And then we need to have a clear way to say, okay, why do you deserve a higher rate than another provider? Because every time we increase the rate for one provider, we have to have a clear justification. And it can't be because of some bias. It has to be because we have a lack of access to care in that space. Maybe the training is longer. Maybe it's a specialized type of treatment that otherwise isn't offered. And we always have to figure out what the business case is for giving those rates away. And so that's why because, again, we're stewards of our patients' premiums. And every time we increase rates, it will increase access. But it comes at a cost. And so where is that line in terms of payers and how we're looking at doing that? Still, it's very difficult for payers to ever get towards a cash pay rate. So we're going to have to depend on providers then to take a pay cut in some ways to work to take insurance versus not taking insurance. So there's a lot there in terms of the payer side that I think we can do. That's going to take collaboration with the other panels here to and straight providers too. By the way, that I know we don't have panels done that, but of course, figuring out how we can get the right mix of incentives aligned, so that we're not kind of all siloed in the various parts of the system that we have, which sometimes gets it makes it difficult to show outcomes when we're all kind of looking at our own pockets and our own piece of the very complicated system that we have.
Yeah, really interesting thoughts, Ish. I got one more, hopefully quick question for you before we transition to Q&A. But I'm curious, are there any specific quality metrics or measured based guidelines that you think are really kind of best practice right now that come to mind?
Yeah, I mean, I'll say that the ones that we look at are always going to be clinical outcomes. So, the standardized rating scales that have been validated are not perfect, but it is one way to look at. Someone mentioned the PHQ-9, G7, and other validated instruments that are used for not only primary care screening, but also direct kind of measurement-based outcomes and care. So clinical outcomes, I think total cost of care is a quality metric that hopefully we'll get smarter with over time and be able to appropriately attribute and show kind of holistic outcomes. Measures of integration is a quality metric for both behavioral health providers and non-behavioral health providers. So how often are they communicating with each other? Are there kind of structural quality measures that there are workflows that exist to do integration and have providers talk to one another? And finally, I don't know if people consider it a quality measure, some people don't, but access is another component that we need to make sure that providers are giving equitable access to all patients, regardless of where they live, their race, their income status, and so forth. So, to me, those are some quality measures that come to mind that we look at that are some are easier to measure than others.
Can I just pick up on that point, Ish?
Absolutely.
Agree completely. I mean, the patient-reported outcomes, PHQ-9s, GD7s, there are a host of them, and those are often the ones that we start with, but there are a host of measures. But I think it's also really important, you raise this point, to look at social drivers as health, social determinants, because we know that clinical care actually only accounts for about 20% of healthcare outcomes, right? We have to look at health behaviors. We have to look at socioeconomic factors, environmental factors that are accounting for so much more than just clinical care. And it's so important that we assess. And there are now mandates to do that for inpatients. There will probably be mandates by CMS to do that for ambulatory patients as well. But what I think where systems can struggle, and maybe our healthcare ecosystem in general, is interweaving the patient-reported outcomes with those assessments of social determinants, drivers of health. And it's so critical to do that because they are interrelated, and we can't talk in a vacuum about treating depression or treating anxiety without taking into account things like the fact that there are huge disparities, that zip codes are determinative, that there are metrics, social vulnerability metrics that look at risk of suicide by zip code, and there's a 56 to 82% increased risk when you compare the most impoverished decile of people living in counties versus those that live in affluent counties. I mean, the zip codes are determinative. When you know that a Black person is much more likely to get diagnosed with schizophrenia than depression. So, the structural racism that's built into the healthcare ecosystem. So these things have to be addressed and really interwoven with the patient-reported outcomes, because what winds up happening is that not everyone is really being asked these questions. And so we have to democratize access to the assessments, democratize access to care, and we've got to interweave the social drivers of health with those patient-reported outcomes in a holistic way to really treat large populations, and to drill it down at individual levels is super, super critical.
Absolutely. Yeah. Thanks for that addition, Tom. And I think that that's actually a really great segue into the Q&A because somebody did ask about, would love to just shoot this over to the panel. And this person asked, how are you and your teams thinking about culturally competent care in behavioral health? So a little open-ended, but would love to, if you guys have any thoughts there.
I'm happy to take a stab at that. It was sort of an extension of what I was just talking about. I mean, we have to recognize that there are implicit and explicit biases that occur within healthcare. And we also have to look at, the demographics of who goes into healthcare, and particularly physicians, and that it's not as diversified a group, particularly in psychiatry and behavioral health. And so, we have to be able to address recognize and address cultural issues. We have to help people to feel comfortable and recognize, negative experiences that have really created barriers to access and barriers to care at all for a whole range of reasons. We know what a lot of these metrics are. Rates of mortality, rates of mortality following pregnancy, based on race and so on. I mean, there are a lot of metrics here, and so we have to be asking the questions first. We have to be asking questions, as I was saying before, that look at drivers of health and look at how environmental and community and socioeconomic and racial and ethnic factors play into that. We have to address them. We have to talk about them. We have to make sure that we're literally sometimes speaking a language that our patients are speaking if they are not, if English is not a language that they speak, or it's not their first language. So there's a lot of work that can be done. Some of that can be done digitally, but we also, have to be mindful of that when we think about how healthcare gets deployed in this country. And we have work to do. And I think that one step is education, education among healthcare professionals, and there's work that's being done in that. Another, as I said before, is democratizing access to care and surfacing psychiatric illness. We know that in certain communities, that psychiatric illness is not surfacing the way that it needs to for a whole host of reasons, and they have to be addressed both from a structural lens as well as a clinical lens, as well as a technology lens. And the reality is, once we start addressing these things, and I don't in any way want to suggest that this should be the driving force, but it is a reality that healthcare runs more efficiently. That's something that we often overlook. It becomes actually more affordable and more economically viable once we start surfacing underlying problems and treating them appropriately, as opposed to what often happens now where people are not being identified or they're being mistreated, and they're being mistreated because we have not had the cultural sensitivity and that we need to have. So there are so many reasons to do that.
Yeah, thanks for the extension to that answer, Tom. Kristen, any thoughts there? Or happy to move on to the next question too.
Yeah, I mean, I couldn't agree more. And I think we could probably do a whole webinar on the topic. It's a huge issue. So I say in the interest of time, let's take as many questions as we can.
Sure.
Awesome. Yeah. Sorry, did you have something to say or?
No, go ahead.
Okay. Sorry about that. So this is kind of a more, sexy question over here, but what are you guys seeing as far as the best use cases for artificial intelligence and machine learning, all the buzzwords in behavioral health and serious mental illness, like engagement, risk stratification, something else, anything kind of tactical there?
Yeah, it's a dicey topic, honestly, at this point. I mean, like for our business, there's a lot of scrutiny and regulation that we're just now starting to put in place relative to it. I think there's a lot of potential just in terms of risk stratification, predictive analytics, but we also want to make sure we're maintaining the human touch, but being more effective and efficient and utilizing the human touch is, I think, probably where we can demonstrate the greatest advantage. And that's in mental health, the psychology of return to work. We struggle with finding the right folks at the right time to engage in even just vocational services. So there's a lot there. That's another webinar too, I think, but I'll turn it over to my friends and colleagues to take it further.
Yeah, I mean, Chris, I couldn't agree more. And you're right. I mean, I refrain from answering because I'm afraid I would talk for 2 hours. I will not do that. But there's so much there. And it's a very exciting time because the AI, look, everyone thought that radiologists, maybe pathologists were going to be out of business, right? Because we were going to have these pattern recognition algorithms and AI. And what's happened is, no, they're not out of business. It's made them a lot smarter. And that's where AI comes in. It just makes humans smarter. We strongly believe, Kristen, to your point, that it's high tech, high touch. I don't personally believe that we can have technology alone. I think technology allows you to provide to facilitate holistic care, to do practice extension so that you can take what goes on in a practice and do it in the comfort of patients' homes and deliver self-management tools that are really tailored toward people's individual needs, that allow you to surface underlying psychiatric illness, that allow you to use predictive analytics to determine those pockets of individuals who are at risk or will be at risk 2 years from now. There are pretty good predictive analytics that do that. So I think it's a very, very exciting time. Using AI. I mean, there are caveats there, but again, I just think, Kristen, your point is so important. It's not replacing human beings. It's just making the system work more efficiently, democratizing access to use that term again, and to be able to scale this in a much larger way. So that's the way I see this.
Anything to add there, or feeling good?
I know I'm feeling good. I'm learning from you all on that front, but I agree with what you all said. I'm excited to see what happens out of it, so it can help our members.
Yeah, likewise. I think that that's a really awesome tune to kind of close this discussion out on. Is just one of optimism and one that everyone is continuing to work in that direction. So first off, I wanted to thank you guys for this conversation. If anybody has any follow-up questions, feel free to reach out to me, and I'm happy to direct them. Will from Neuroflow and Neuroflow in general, thanks so much for sponsoring this webinar. I'd love to give you the floor and just kind of close us out here.
Yeah, well, again, a big thanks to Blake and the hospitality team for putting this event together, and thanks to the attendees and their questions. And of course, a big thanks to our panelists for their thoughts and insights during this great discussion. The Neuroflow team will be out at Health Vive in LA later this month, so feel free to stop by and say hi, or if you want to learn more, head over to our website at neuroflow.com. But thanks again to everyone. Really appreciate the event.
Awesome. Thanks all. Have a good rest of your day.
Thank you.
Thank you
For having me.